Welcome to Altea Talks, the brand new podcast series being brought to you by Altea, the unique provider of combined insurance and risk management solutions designed exclusively for the medical, allied health and care sectors. I'm going to be your host, Will Marshall, and I'll be joined in this series by some of the leading movers and shakers from across the sectors. My guests are going to include practitioners and professionals, regulators, clinical risk and governance specialists, and an array of legal experts who are going to help us get to the heart of the hottest topics affecting the UK's health and social care sectors today. So, if you're looking for frontline knowledge and expertise, if you want valued insights into these most dynamic, challenging and rewarding of sectors, then look no further because you're in the right place. Welcome again to Altea Talks. Hello and welcome to the latest episode of Altea Talks. This is our regular podcast series in which we aim to get to the heart of some of the most important, topical and relevant clinical, regulatory and legal issues facing the health and social care sectors in the UK today. Our focus today is on the non-surgical aesthetics sector, and I'm delighted to be joined by our very distinguished guest, Dr. Catherine Fairris. Dr. Fairris is a highly qualified and experienced aesthetic doctor. She is director of the Wessex Skin Clinic in Winchester, which specialises in providing minimally invasive aesthetic and skin treatments. The clinic's focus is on providing its patients with the highest standards of evidence-based clinical care, meaning that all of the treatments and products on offer are meticulously researched for their efficacy and safety. In addition to her impressive clinical work, Dr. Fairris is the current president of the British College of Aesthetic Medicine, BCAM. BCAM is the UK's leading representative body for doctors and dentists practicing aesthetic medicine. It represents around 400 medical professionals providing treatments that include Botox injections, injectable fillers, chemical peels, anti-aging treatments, and body sculpting. Welcome, Dr. Fairris.
Hello, thank you for having me.
It's an absolute pleasure, and we have so much to talk about in today's episode. It seems to me that the issue of regulation, or should that maybe be the lack of regulation in the non-surgical aesthetic sector, is rarely out of the news these days. And we seem to lurch from one scare story to the next, whether that's fake Ozempic pens being seized by the MHRA or unregulated non-surgical filler being used as an alternative to the Brazilian butt lift procedure. What's going on, Catherine?
Oh, I really don't know, but what's happening is actually really interesting. It's a little bit of a perfect storm. Aesthetic medicine is not in itself a branch of general medicine in the UK, although it really should be. And what's happened is over the years, none of the specialities of medicine have had full ownership of it. And what's essentially happened is that it's become an area which anybody can dabble in. And it's almost been ostracized as a beauty treatment predominantly. And as a result, many non-medics practice it. And that was fine when all we had, well, it wasn't fine, but that was okay, I suppose, to a certain extent, when all that was available was perhaps botulinum toxin injections. What we're having now is a perfect storm where we have more innovation and technology in aesthetics. So aesthetics has been pushed beyond just simple skin or surface treatments to more invasive treatments. And the regulation that has never existed is now even more desperately needed because the risks that are being taken, the degree of risk associated with the procedures that are available are growing rapidly. So what we're seeing essentially is more treatments that are more invasive being made available, and unqualified people who have already been practicing for a long time now taking on these very dangerous and risky procedures.
Yeah, and demand just seems to keep on increasing for these procedures.
Yes, recent data by one of the large pharmaceutical companies looking at interest in aesthetic procedures has shown a significant number of people are willing to try. And I think it's also to do with the social media world that we live in, where beauty and appearance is very much more an important part of our daily life. So people want to put their best foot forward for whatever reason. They're on social media more, they're posting more. And therefore, the need to look good and potentially undergoing procedures to make themselves look good is more widely accepted. And actually advertising procedures or talking about procedures, it's now more widely accepted. People are open about the procedures that they've had and what they have done, which almost normalizes it in society, and therefore more people are willing to try and have these treatments.
Yeah, I mean, it seems like we're always, all of us, on camera in some way, shape or form, whether that's through a Zoom call or through a selfie or whatever it is these days.
Absolutely.
And so the government has responded or is in the process of responding to this gap in regulation. And we've obviously had the bare bones of the new licensing framework shared with us through the Health and Care Act or introduced through the Health and Care Act last year. We've had the Department of Health and Social Care's consultation looking to put a little bit more flesh on the bones on that recently. And I know that BCAM have responded to that. As far as I'm aware, the government hasn't yet issued its response to the responses to that consultation.
That's correct. There hasn't really been much of a time frame also solidified. So there's been a rough discussion of the potential time frame. And I think it's been postulated that 2024, 2025 might see the next step in the process, but we're still waiting for the response from the government.
Yeah, it's fair to say that you and your colleagues at BCAM are supportive of establishing a legislative framework that enforces the need for appropriate training and standards for all non-surgical cosmetic practitioners. Why do you say that's so important?
It is fundamentally important because, as I've said earlier, a lot of the procedures that are available under the umbrella of aesthetics are invasive procedures or involve prescription medications or have a significant amount of risk associated with them. So I'll actually go back and say it's really important to understand that doctors, nurses and dentists who practice aesthetics already practice within a very different standard to the general public. We're already very highly regulated. We are accountable to our professional bodies. We are accountable to our insurers. We are accountable to on so many different levels. Whereas what we have is a group of people practicing who have no regulatory responsibility, who are not under any obligation to put patient safety first or put client safety first. And as a result, we're seeing a two-tier system. And the new consultation, the regulations that the government has proposed, is looking predominantly at regulating non-medical professionals. And our argument to start off with is, well, why are we even allowing these people to perform some of these procedures? And actually, there should be certain procedures which should just be banned. Going on from that, anybody who's performing any of these procedures should be trained to the highest level possible and be under the best supervision that's available in order to, and I think that's the key, in order to protect the general public and protect the people undergoing these treatments, because that ultimately is what the focus should be.
Yeah, but surely there's space for some non-medics in the sector.
And I think that's really interesting. So I own a clinic and I have a aesthetic practitioner that works with me, and she performs IPL under my supervision. She performs microneedling. I'm not in the camp that says only doctors can perform any aesthetic treatments. That's not the argument. The argument is that people should only operate within the realms of their expertise and training. Aesthetic practitioners have a lot of training and expertise within certain treatments. So my aesthetic therapist can perform chemical peels. She performs superficial chemical peels. And I feel comfortable, with her doing that. She's incredibly experienced and qualified. The problem is there is no distinction in aesthetics currently that relates to what's dangerous and what harm can be caused. So, for example, anybody can buy a high-level laser, erbium YAG laser, and start performing tattoo removal or laser hair removal or pigment treatment. But these lasers can cause significant harm. They can cause blindness. They can cause severe burns. If used in different skin types that are not suitable, they can leave scarring. And these aren't necessarily things that regulation currently protects people from. So what all we're saying is, first of all, categorize and identify procedures that are incredibly dangerous or high risk and stratify that risk by regulating who can perform them.
Isn't the point that really it comes down to the knowledge, skills and ethical standards of the individual practitioner, and that's where the regulation comes in and the training that will be part of that? You touched earlier on one of the issues being this proliferation of treatments that are available now, and we've also mentioned the sort of the increasing number of people who are seeking these treatments. It seems to me as a layperson that one of the difficulties with introducing a regulatory framework is really how can it keep pace with such a dynamic and evolving sector? And what's your views around that?
No, absolutely. I completely agree. But that's an argument that can be applied to any situation. Look at AI. How will regulation keep up with the potential that AI has? I think it's important that regulation is continually reviewed and assessed, and there needs to be safeguards in place so that if a treatment becomes or arrives that is incredibly dangerous or that we are finding is associated with significant risk, there needs to be some maneuverability within regulation that will allow that procedure to be escalated into the appropriate category. For example, you talk about technology and advancement in aesthetics. The new frontier we're seeing an introduction of something called polynucleotides, and we're seeing an introduction in stem cells. And there's a lot of excitement and buzz around these two treatments. Stem cells obviously coming from extracting the stem cells from either plant or animal derivatives and then injecting them into the skin, because we know that regenerative properties of stem cells. But actually, some stem cells are on the market that we suspect might be human-derived. Now, that's a massive risk because we don't necessarily know where they're coming from and what safeguards have been in place in their production, but there's no regulation around that. So regulation needs to be robust. And that's why I think whatever regulation comes into place, the government or the Department of Health and Social Care need to involve those operating on the ground level, the people at the shop front who are using these technologies and who are involved in the development of these technologies. But at the moment, we're seeing potentially a mismatch because the Department of Health and Social Care, I don't know how close they are to the actual practice of aesthetics and what's actually going on the shop front. And that'll be interesting. But yes, regulation needs to be robust. There needs to be maneuverability and it needs to change with the times. But ultimately, there should be some fundamental or baseline regulations that we can draw upon. At the moment, we have nothing.
Yeah, I mean, there's a lot of noise, isn't there, at the moment about engaging with stakeholders and so on in framing the regulations. But it does seem to me that it's such a moving target, really, that it's quite difficult to have a list of treatments that would be in your red category, your amber category, and your green category without having that under some sort of continuous monitoring and reevaluation to keep pace. Can I just move on the licensing scheme? What do you think about the government's proposals to modify the existing regulations to bring high-risk aesthetic procedures under the CQC's oversight and get the CQC involved in that?
Yeah, so at the moment, the Care Quality Commission, or CQC, regulate medical properties or medical platforms. So, for example, CQC regulate doctors, they regulate hospitals or clinics or places, and they have a very stringent criteria of what they regulate and what procedures are involved and under their legislation. And what the government has proposed is that certain procedures should automatically be brought under CQC legislation and jurisdiction. So, for example, one of the things that have been proposed are the injection of dermal fillers or the such into the genitalia or genital regions. And I think that makes complete sense. Intimate injection of fillers should be something that is only performed by doctors on CQC regulated premises because they come with such high risk. So certain procedures are very easy to identify as high risk and are logical in their inclusion under the Care Quality Commission. The difficulty, though, is there is a real argument as to what should be involved. And I think if depending on who you ask within aesthetics, in doctors, other stakeholders, there may be a lot of argument around what they believe should automatically fall into that legislation.
Yeah, and I guess the other issue on that is a practical one about whether the CQC actually has the capacity to effectively take on a whole new sector, given the stories that we hear about how stretched it is at the moment anyway.
Yeah, good point. So what's interesting is that the CQC currently regulate prescription treatment. So for example, my clinic is CQC registered. The CQC are not registering me because of my injectables practice. They're actually regulating me because of the fact that I can prescribe antibiotics or steroids within my treatment. So if I am inspected by CQC, they will already look at my premises and already look at all the other things I do, but they will exclude my injectables practice. So to a certain extent, it's not that much more work for them. For example, the fridge that I have on my premises, if I'm inspected by CQC, I need to document that I am measuring the temperature regularly and maintaining the temperature within safe range. But why do I have that fridge? I have that fridge to hold the botulinum toxin that I have to keep refrigerated. They don't care about the botulinum toxin currently, but if I have a fridge on the premises, they will look at it. So it seems very odd to me. But essentially, I do agree that the CQC is very, very stretched. And following COVID, there has been a backlog of inspections. And I know that they're currently undergoing a change in structure on how they inspect buildings. I don't necessarily think it would be that much more hard work for them, as most aesthetic clinics are already CQC registered in some way, or already fall into that bracket in some way. Anybody who prescribes medication that is treating a disease in any capacity needs to do that on a CQC registered premises. So actually, it's not that much more of a stretch for them, I don't think.
Yeah, and the new licensing regime, when it comes in, is going to apply to premises as well as practitioners, isn't it?
Yes, they are proposing a two specific licensing areas. So the practitioner can be licensed and the premises can be licensed. Although there's some discussion about environmental health and local government taking on the responsibility of licensing some of those, of being involved in regulating that licensing of the premises.
Yeah. Okay. So if we just look at the recent consultation, and the government proposals were to categorise the various types of treatment on a green, amber and red traffic light system. I think you've got some concerns, haven't you, about whether having that sort of system adequately addresses the nuances of risk associated with the different types, the vast number of different types of aesthetic treatments that are currently being performed.
Absolutely. I think, Will, you mentioned earlier, you said, surely it's about people operating within the realms of their expertise. So, for example, back to IPL, I use that as an example, intense pulse light. It is a modality that we use very widely in aesthetics, and we use it in medicine as well. But in the context of aesthetics, if I have an IPL machine, I can not only do hair removal treatments, but I can also treat acne and pigmentation and acne rosacea and so on. If I have that on my premises, if I have an IPL machine on my premises and I say, well, environmental health officer who's come to inspect my premises, I only use it for hair removal. That's fine. But the reality is that's a machine that potentially has the potential to do other things, and it has the potential to potentially cause harm. How is that going to be regulated from day to day? In the same way, for example, the green, amber, red method of stratifying the risk of procedures, they have placed injectables currently in amber. But we all know, for example, if I'm in a clinic that has dermal fillers on the premises, how will you police how those dermal fillers are used when we've already identified that injecting them into people's genitalia should be red, but that injecting them, for example, into people's lips should be amber? But who's policing that? Once the client is on the premises and being treated, how will we distinguish and identify what should and shouldn't be done? And the other thing to say about injectables is, specifically with dermal fillers and treatments in that category, it's not necessarily the product themselves that is the harm. It's about who's injecting them, where they're being injected, how they're being injected, and an understanding of the risks associated with the technique of injection. So we often, when we talk about dermal fillers, will identify zones within the face, for example, that might be high risk to inject compared to other areas that aren't as high risk. those nuances won't necessarily be obvious if someone's just inspecting a building, or if somebody's just saying, well, that all the treatments that are used as dermal fillers are amber. No, depending on how those dermal fillers are used, they can be incredibly dangerous and come with a lot of risk, but they can also be relatively low risk. So I think there's a lot more nuance to just simple red, amber, green. And I think the government needs to really sit down with specialists who, like I said earlier, are on the shop floor and get some really good feedback and advice, because simply categorizing as red, amber or green is not sufficient. And I think I speak for a lot of aesthetic doctors and medical specialties.
And the nurses.
And nurses, yes. The nurses are very clear about their thoughts.
The BCAM response as well.
Yeah.
And I mean, do you think that's going to happen? Do you think that the government is going to listen, or will it just steam ahead with the current proposals?
I hope they listen. What has been proposed is that the second round of consultation will be a more closer sit down with the main stakeholders. They haven't identified necessarily who those stakeholders are, although in the past, the British College of Aesthetic Medicine, BCAM, have been invited, and we have had a seat at the table, similarly with the JCCP, the Joint College of Cosmetic Practitioners, BACN, and so on and so forth. So we hope that they will take our feedback seriously. And I really do hope that there is an open and honest discussion about patient safety. That this is ultimately what this is all about. You know, what's really interesting is that I was in London the other day and I was walking around and I happened to notice the number of clinics offering aesthetic treatments. It's like bread on the shelf at Tesco. You can come to the shelf and buy your Tesco's Basics white bread, or you can go for your farm seeded batch expensive bread. But we're all buying bread and we're all buying it from this one place, but there are multiple different types of bread available. Extending that analogy to aesthetics will always be available. There'll be lots of different clinics, but people will choose where they want to go to receive treatment. There are some, my patients specifically look for a medical professional who's experienced, who's going to do things in a specific way. And there are other people who are happy to find a practitioner off of Instagram and go to them in their house and be injected in their kitchen. I'm not saying those are right, but what I'm trying to say is ultimately whether that person is being treated in a CQC registered hospital or they're being treated in a high street clinic, the standard of care that they receive should be the same. And that's what we should be striving for ultimately, is patient safety. People will always choose the category of where they want to go in terms of what their funds are and what their life experiences are. But we should be sure that whatever treatment they're having, the minimum standard of care has been set to ensure their safety. And I think that's what we should all be striving for, personally.
And that would be reflective of sort of health care anyway, where there's a duty of care owed by the practitioner to the patient.
Absolutely.
And that would certainly be how the law would look at it.
And that's the thing. I think it'd be great to have some regulation to fall back on, because at the moment we hear such horror stories. We see such horror stories of people being put at significant harm. But there's currently nothing that they can do. There's no recompense for those patients or for those people. So, for example, we hear stories of people ending up on ITU having bought fake Ozempic pens, for example. If that was a doctor that had caused harm, there would be a clear pathway for that person to seek help, support, compensation, ensure that that doesn't happen again to someone else. But when it's a non-regulated person that's done that, there's no comeback. We've actually tried. The British College of Aesthetic Medicine, we were sent a clip of a beauty therapist performing liposuction in the middle of her clinic, of her shop, her beauty salon. And it was live on Instagram. And she had inserted what was essentially a metal pipe into this person's tummy and was extracting, moving fat around. And this clip was sent to us and we were like, what is this? Genuinely shocked, horrified, and concerned for the safety of the patient. So we thought, okay, what can we do? We tried calling the police. No, there's nothing, no crime has been committed. That person has chosen to participate in that act. We tried calling environmental health. They didn't have the address, but ultimately they said, well, if that building is beauty salon and that person is operating within the requirements of beauty salon, they've done nothing wrong. We couldn't report them to their governing body because they don't have one. We couldn't necessarily report them in any other way. We were essentially stranded. We had nothing that we could do for that person. Now, we don't know if that person came to harm. We may never know. But that is a very scary thing to be out in the world for other beauty therapists to see, and for people to think it's okay for someone to be performing essentially liposuction in the middle of a beauty clinic. It's just bizarre.
Yeah, bizarre is the word. And I suppose that individual would potentially have had a legal claim, or could have made a legal claim for damages. But then that raises the issue, doesn't it, about insurance? And
yes.
One of the sensible proposals, I think, with the new licensing scheme is for there to be mandatory indemnity insurance as a requirement on all practitioners. And again, that's something I think you'd be supportive of.
Absolutely. So at the moment, as a doctor, I have to have a certain level of indemnity cover, and annually have to demonstrate as part of my appraisal that I'm keeping that up and that I'm maintaining a certain minimum level of cover. This does not apply to non-medical healthcare professionals. So it's really important that I think what doctors want is if we put the same level of responsibility onto people who are practicing this, who are non-medical professionals, it may very much change their view. So, for example, I, as a medical professional, need to do 50 hours of CPD annually to demonstrate that I am maintaining a basic level of experience, qualification, keeping up to date with my professional development. I have to have a certain amount of indemnity, which costs money. I operate from a CQC premises. I have to have certain level of basic life support. My staff have to be trained, etc., etc. A clinic that opens down the road by a beauty therapist doesn't have to do any of that, doesn't have to demonstrate any basic level of safety or experience or qualification. They can literally just start doing the exact same things I'm doing in my clinic without any level of experience or qualification or safety net at all. The average person on the street doesn't know that. And that, I think, patient education or public education is really important, because that may deter a lot of people in the first place. But because these treatments have been so widely available and so easily accessible for so long, the average person on the street doesn't realize that they are potentially dangerous or that only certain people should be performing them. And that's why they end up in the situation where they put themselves potentially at risk. And we've had feedback at BCAM where people have tried to contact whoever's injected them via WhatsApp and just been blocked, or told, oh no, it's just a bruise, it'll resolve in a couple of days, when it turns out it's something more sinister, an infection, vascular occlusion. And then that person is left having to pay more money to a professional to have it resolved. And again, they have no record, but there's no going back to the original person, because that original person didn't owe them anything legally, professionally.
So the new licensing framework is coming, we're told, and it gets a little bit more sort of grey when people talk about the timescales for that coming. I mean, what's your view about that? Where are we going next in the evolution of this licensing framework? What are we going to see in 2024?
Supposedly in 2024, there should be a sit down of main stakeholders, and that means currently the main organizations representing aesthetics. So the beauty industry will have representation from a aesthetic practitioner's point of view. Medical professionals will be invited, and I believe that will be, so the BACN, the British Association of Cosmetic Nurses, the British College of Aesthetic Medicine. I'm hopeful that BARPS, the British Association of Aesthetic Plastic Surgeons, will also be involved in this conversation. And then there'll also be people such as the JCCP, the Joint College of Cosmetic Practitioners, and so on. So the idea is to bring all the main stakeholders together and really, excuse the phrase, hash this out in a way that is beneficial. What we as medical professionals really want is for there to be a patient-centered, public-centered approach, in that patient safety, public safety should ultimately be at the center. If we decide that, for example, the CQC are going to regulate a significant amount of this area, that shouldn't be the reason why we don't include certain treatments under CQC regulation. We need to put safety first and then work from there. And ultimately, the evidence suggests that medical professionals are going to do that, or have the strongest sets of skills that will allow patient safety to be at the center of their practice.
Yeah. We've talked a lot today about regulation of individual practitioners. We've talked about regulation of premises. And you've touched on the issue about the accessibility of unregulated cosmetic products. How broadly do things like the Ozempic fake pen scandal reflect a more extensive concern about the marketing, distribution, and accessibility of those products?
Yeah, it's really interesting because let's look at botulinum toxin. That is a prescription drug. It should only be supplied by a licensed pharmacist under prior prescription by a doctor. Yet you can walk into the majority of beauty salons up and down the high streets all around the UK and be offered botulinum toxin injections or anti-wrinkle injections. Not all of those products are being supplied by doctors' prescriptions or from registered pharmacies. We know that because the MHRA have actually done raids. I think the most recent raid was in the west of England, where they were able to confiscate significant amounts of unregulated toxin coming from countries where regulation in their production isn't necessarily traceable or of the high standards. So essentially what I'm trying to say is there is an influx or there's accessibility of unregulated medicines or unregulated other products that we use in aesthetics coming in. And the difference is, as a CQC registered premises or as a doctor, you have a duty of care to be able to, provide, there is regulation over the products that you use. So for example, I can demonstrate where all my toxin comes from. I have to keep a record of my prescriptions. All my prescriptions are, electronically generated. And should there be a problem, I can trace the product that I've used back to the pharmaceutical company that I've purchased it from. Again, the same cannot necessarily be applied to non-medical professionals. Then we look at dermal fillers. So dermal fillers are non-prescription medications. They're actually considered medical devices. Now, the regulation around medical devices has very much changed. And in the UK, there are potentially up to 200 different dermal fillers available that you can buy, even from Amazon. Whereas in the States, dermal fillers are considered a drug, or they can only be injected or provided by medical professionals. The difference is in the States, there are only a handful of dermal fillers available. And those dermal fillers have had to demonstrate clinical efficacy, safety. So they've had to undergo more stringent testing in order to be available. What does that mean? It means that the people turning up to beauty salons to have their bodies filled with dermal fillers for BBLs, what is being injected into them? We're not necessarily sure where they come from or what potentially the risk associated in those products will be in many years' time. And I'm going to refer you to the breast implant scandal.
Yeah, the PIP scandal.
The PIP scandal.
Yeah.
And those breast implants weren't prescription, they were just medical devices that were allowed to be surgically implanted into people. And subsequently, we realized many years later that they were causing harm. We're potentially in that position.
We're sitting on a potential time bomb.
We really are, because not all the dermal fillers that are being used are rigorously tested or come from pharmaceutical companies that can back up their efficacy and safety. And that, for me, that's another thing that I think we need to look at is the production of injectables and where they're coming from, what evidence base do they come from, and what safety profile is associated with them, because that's necessarily something that's being done currently.
And has the position been made worse in that regard by Brexit?
Yes.
Yeah.
Yes, because prior to Brexit, you had to have a CE mark. There was a basic level of safeguarding in place. That isn't necessarily the case anymore. Since Brexit, you don't even need a CE mark on your boxes. And
turning to the sort of marketing and advertising side of it, what's your experience about is it being targeted at younger people in your experience now than previously, or is that just another scare story?
Oh, no, this is a really interesting conversation. So I went to my daughter's school Christmas dinner for parents the other day, and I sat next to a woman who's in her early 40s, and she knows what I do. She turned around and we were having a conversation. She said, "Oh, do you like my lips? I just had my lips done, da, da, da." And I was like, "Oh, they look lovely." And she went, "Oh, I had them done from this lady who I found on Instagram. She had amazing photographs and da, da, da." I was like, "Oh, right. And was she a doctor?" She went, "Oh, no, I think she was a mental health nurse." And conversation went on. And that was really interesting. This is a woman in her 40s who essentially shopped for new lips on Instagram and found her injector on Instagram. You look uncomfortable, but this is happening up and down the country. And what's really interesting is there was a recent, I think it was Allergan, one of the large pharmaceutical companies, did a survey. and they took people from different walks of life, different ages, and they asked them where they get their information from. Where do they do their research from? And the evidence is, not just from this Allergan study, but I'm sure other studies can back it up, that more and more people get their information from social media, and more people shop for things on social media. Now, if you put this into perspective, in the UK, as a doctor, I am not allowed to advertise prescription medications or mention prescription medications on any platform, let alone social media. So who can do that? Who's allowed to do that? Well, non-medical professionals. So we're in a position where people are getting more and more information from social media. The people who can freely advertise on social media are the people potentially who are not professionals. They have more access, patients, to the general public than we do. But all that aside, I think advertising is growing. And I know more and more doctors are using social media to advertise because, you kind of have to, if you can't beat them, join them kind of attitude. And social media is a very powerful tool. We shouldn't underestimate it. So what we need to ensure is that regulation also covers what can be shown. So for example, we all know that on social media, you can doctor photos. You can make photos look really good. You can change lighting. In the way there are filters for photos. So there should be some regulation on what people can say in advertising, what people can show in advertising, and the minimum amount of honesty that's required. So, for example, there should be regulation that states that your photographs can't be doctored. So the Advertising Standards Agency have recently prosecuted quite a lot of people in and around aesthetics for false advertising or for making promises that they can't back up. But it'd be really useful if there was more stringent regulation on that, because I think a lot of people are susceptible to social media marketing, and that's where a lot of people get their information from.
It's a fascinating area, the sort of tension between advertising and sort of providing proper information so that somebody can give fully informed consent.
Exactly.
I've certainly seen in some of the legal cases that I've dealt with examples where practitioners are showing patients not just what it would look like if it goes well, but also this is what it could look like if it doesn't go so well.
Yeah, that's probably very wise.
Yeah, well, I don't think that happens too often, to be fair. But just before we finish, I just wanted to ask you about one other aspect of your world. And it's really, we've seen over recent weeks quite a lot of press talking about high-profile incidents that follow cosmetic surgery, and I appreciate you're not a cosmetic surgeon, but arising from the growing trend for people to travel abroad, cosmetic tourism, to get cheaper cosmetic treatments or more cost-effective. What's your views about that? What steps do you think could be taken to protect the safety of those individuals?
Medical tourism is really interesting because it's growing rapidly. And we know that to have cosmetic surgery in the UK is incredibly expensive, but it's incredibly expensive because UK doctors have to be incredibly well trained. They have a minimum standard of care that they have to provide for their patients. Therefore, that comes with money. If you can wrap a holiday in an exotic or warm climate with having, and even dental tourism, so having your teeth done or having your hair transplant or having your BBL, that can look very attractive to people. But what people don't necessarily realize is that the duty of care of those countries ends when you leave that country. So first of all, you have to get there, have your operation, understand the language to be able to consent or to understand the procedure that's happening to you. And we see a lot of people who end up falling into situations where they're stranded abroad in a hospital with complications, struggling to communicate with their surgeons or even struggling to get back home. Medical tourism needs to be looked at because there is an argument that access to medicine shouldn't be restricted based on price. And you can argue that the reason why procedures or treatments are so expensive in the UK is because of the tax associated, etc. So I think it's important to understand that one of the things that pushes people, a strong push to send people abroad, is money. And if there are any ways that treatments can be provided at a more cost-effective way, number one. But number two, again, back to patient education, patients need to understand. So for example, if you have your treatment abroad and then you come back to the UK, the NHS is under no obligation to rectify a cosmetic problem. They can obviously, and they will support you acutely if you're unwell, but people coming back with botched procedures, they often have no safety net because, for example, you go and have breast augmentation and you come back with an infection. The NHS will manage you and look after you from that perspective. But say you suffer significant changes to the surface of the skin requiring further surgery to cosmetically rectify the situation, you may end up having to pay for that yourself. And a lot of people don't necessarily realise that. So I suppose, what was the original question? Sorry,
Well, I was just wondering what steps you thought could and should be taken to protect the safety of people who are travelling overseas for cosmetic treatments.
It's got to be education. It's about them understanding the risks that they're taking. Sadly, you can't ever stop. If someone's of sound mind and making the choice to go abroad because it is significantly cheaper, there'll be a significant proportion of those people who will be fine and have a very good experience. But it only takes one death or one significant complication for us to understand that these are significant risks that people are putting themselves in. And they need to understand that, unfortunately, the same standard of care that they get in the NHS may not always be the standard that they can expect or will expect when they go abroad. And that it's more than just a holiday. I think there is a general, I don't know whether it's a generational thing, but a lot of people now don't see certain cosmetic procedures as fairly trivial and don't necessarily realize that actually a lot of cosmetic procedures are invasive and come with a lot of risk. But because they're seen as beautifying, they're often trivialized. Oh, it's just a BBL. Oh, it's just breast augmentation. But it's still major surgery, comparable to, undergoing laparoscopic surgery, for example. We consider that to be major surgery, but we wouldn't necessarily feel comfortable going abroad to have it done. Whereas a lot of people do. And I think it's maybe changing the perception of the public and really educating the public on the risks associated.
Yeah, and those risks would, I guess, go beyond the physical risks of the procedure and what could be complications of the procedure, but also the importance of choosing appropriately qualified and experienced practitioners to actually do the surgery. And you would have, it seems to me, potentially at least have a lot less information about who's going to be doing it than you would if you were having that same treatment in the UK. Absolutely.
I think you've you answered the question better than I have. That's incredibly relevant. In the UK, you would have potentially a lot more autonomy, and the process of consent would be potentially a lot more rigorous than if you are abroad, and not only the language barrier, but the way the healthcare system might work in a different countries may be different to what you understand it to be or what you're used to. So yeah, absolutely.
Well, we could talk about this subject for a lot longer and go on and on, but I'm conscious of the time, and I think this is probably a good place to come to an end. It just remains for me to thank you very much, Catherine, for being such a great guest and being so interesting about so many aspects of this. And it really is a very interesting space. There's a lot going to be happening in 2024. I do hope that some of the issues that you've touched upon today, at least there is a plan in place to address some of those problems and that we're moving in the right direction.
Yeah, no, thank you for having me. And yes, very optimistic that there will be some improvement, or at least a move towards better regulation or minimal level of regulation to protect the general public. So exciting times ahead.
Okay, well, let's watch this space. Thank you very much.
Thank you.
Thank you for tuning in. I hope you enjoyed today's episode of Altair Talks. If you did, please don't forget to subscribe or leave a like or a review on whatever platform you're listening on, as this helps spread the word. If you have any questions or comments or topics you'd like us to explore in future episodes, please do contact us, as we'd love to hear from you. You can find us on LinkedIn or visit our website at www.altairinsurance.com. Stay tuned for more episodes, and until next time, take care of yourselves. The information contained in this podcast is not intended to represent a complete analysis of the topics presented and is provided for information purposes only. The views expressed are personal to Dr. Fairris and Will Marshall and do not necessarily represent the views of the British College of Aesthetic Medicine or of Altair Insurance Limited. The content of this podcast is not intended as legal advice, and no responsibility can be accepted for any reliance placed upon it. Independent legal advice should always be obtained before applying any information to particular circumstances.